Start this presentation with this guideline recommendation from the European Association of Urology guideline, and I'm going to start with this and finish with this slide. But now I want to tell you something. In every place you can see androgen deprivation therapy is part of the treatment. So I want to give the credit where the credit is due. This is Charles Hagen, and this is the first paper that document and recommend androgen deprivation therapy in patients with metastatic prostate cancer. That was in 1941. And this groundbreaking research showed that reduced androgen level either through either through surgical castration with orchiectomy or with continuous estrogen administration result in a regression of metastatic prostate cancer. Charles Hagen thereafter got Nobel Prize in Medicine in 1966 for this discovery. And it remains the sole treatment for metastatic prostate cancer. And with ADT alone, the median the median survival rate is about 50 months. And this is heterogeneous actually, depending on the primary stage, grade, and degree and volume of the disease. But the question is, do we need to treat all patients immediately? The answer is yes, with one exception. The delayed or deferred treatment of androgen deprivation therapy is recommended in patients who have very limited life expectancy, such as patients with less than 1 year for comorbidities other than cancer, or patients who are asymptomatic and strongly wish to avoid side effects. So we have to treat those patients with androgen deprivation therapy. Let's start with this. One of the most surrogate markers for response to androgen monotherapy is PSA. And I'm telling you this because later I will tell you the same fact that till now, the response in PSA is one of the most important markers to the overall survival and other survival outcome. Now, the current data shows that if we intensify the androgen deprivation therapy with androgen pathway inhibitor, such as abiraterone, apalutamide, enzalutamide, or with chemotherapeutic agents such as docetaxel, there will be a dramatic improvement and prolonged survival. Now, somebody might ask, how about the older generation non-steroidal anti-androgens such as piclotamide, flutamide, nilotamide? Actually, yes, there is an improved survival outcome, but it's less than 5%, and the side effect profile of these medication outweigh the expected benefit. So we should not use piclotamide, nilotamide, flutamide with ADT on those patients unless other agents are not available or contraindicated. Now, these are 10 landmark randomized controlled trials that changed the clinical practice. And many physicians, when they read about these trials, it's like a maze for them. Stampede, charted, blah, blah, blah. So I made some cards for you just to summarize each trial and start the story from 2013 when the Uro-Oncology Working Group and l'Association de France Joint Commission ran this trial, and that was the first trial to assess docetaxel in addition to androgen deprivation therapy in patients with metastatic hormone-sensitive prostate cancer. And despite the author didn't find clear survival outcome, they reported improved overall survival. Then 2 years later came the charted trial, which is one of the big trials that changed the clinical practice to docetaxel as an add-on treatment to ADT, and it showed that it improved survival outcome in patients with high volume disease. And this is the definition of high volume disease: more than 4 bony mets, including one outside vertebral column and pelvis, and or visceral mets. And the Stampede trial, this is one of the most important trials in prostate cancer. This is multi-arm, multi-stage trial, so the trial is still running since 15, 20 years in UK, Switzerland, and most recently in Germany. And one of these arms assessed the docetaxel, and again, it showed improved survival outcome. And the most common adverse effect in this case is neutropenia, febrile neutropenia, fatigue, and all the known side effects of docetaxel. The Stampede trial also assessed other newer anti-androgen, and the story started in 2017 with abiraterone acetate and prednisolone. And this combo reshaped the treatment guideline, and at that time it became standard that you give abiraterone and prednisolone, and it showed improved survival outcome. The safety profile, it showed increased rate of hypertension, liver function impairment, and electrolyte disturbances. The Latitude study showed similar results regarding abiraterone. In the MIT, it evaluated another agent of a newer anti-androgen, which is the enzalutamide, and they reported improved survival outcome in terms of overall survival and progression-free survival. The side effect profile show higher rate of fatigue and seizure, and the author reported it's manageable. The ARCHES trial also assists enzalutamide. While the author failed to reach the primary endpoint showing clear overall survival benefit, they reported improved radiological free survival. So then came the Titan trial, or Titan trial, the apalutamide plus androgen deprivation therapy in metastatic castrate-sensitive prostate cancer. This is a randomized double-blind placebo-controlled trial. It assists apalutamide plus ADT versus placebo versus, and ADT. The primary endpoint were overall survival and radiological progression-free survival. The author demonstrated that apalutamide plus ADT significantly improved overall survival in patients with metastatic prostate cancer. And again, it reshaped the clinical practice by offering a new treatment option. But now, as you see, I showed you many trials, all important. All of these trials showed that if we added a systemic treatment to ADT, there will be an improved survival. So let's agree on something. ADT alone is not enough. So which one to choose? So here comes the details. I have to state clearly that there is no head-to-head comparison between agents, but let's say the Latitude, the ARCHES, and the Titan trial said that there is a risk reduction by 1/3, okay? But the authors of the Titan trial said that 40% of patients crossed over. What does it mean? In oncology trial, crossover mean that participant in the control group can shift or switch from the control arm to the experimental arm in 2 cases, if there is progressive disease or if there is demonstrated improvement in the experimental group. So in this study, 40% of patients cross over, and the final net benefit is 48% reduction in the risk of death in the patient who received apalutamide and ADT versus ADT and placebo. This was demonstrated in both high volume and low volume disease, and this is important. One of the secondary endpoints in the Titan trial is the progression or secondary progression-free survival. And this is one of the interesting endpoints in oncology trial. You do not assess only the first event of progression, you also assess the second event of a progression. In metastatic prostate cancer, when the patient, in hormone sensitive, when patient progress, you start another treatment and you follow the patient. And this is what they do, what they did in the Titan trial. They followed those patients after the second treatment, and they assessed the second progression-free survival. Patient in the, you can see the Titan trial, patient who received apalutamide and ADT enjoyed higher secondary progression-free survival as compared with patient who didn't. And this is the Spartan trial, which evaluate another, I'm not discussing it, but it discussed another disease state, which is non-metastatic castrate-resistant prostate cancer. And you can see apalutamide reduces the risk of second progression regardless of the choice of hormonal or taxane. So if the patient progress, either if you try hormonal or taxane or docetaxel, apalutamide showed positive result or survival results. This is the real time, the real world data, and usually the pharmaceutical like always to present this data, because you know interpretation of the randomized trial is a bit rigid, even if you do post hoc analysis and all these things. So those 2 studies were presented in ASCO GU, and while they didn't show like strike differences between abiraterone, enzalutamide, or apalutamide, they performed an adjusted hazard ratio, and they showed that apalutamide is better. I didn't show the data because it's not peer-reviewed, it's not published up to the best of my knowledge, but the PROMPT-1 study is already out and it's published, and it's discussing another topic in oncology, which is the PSA drop. The higher the drop, the better the outcome. The faster the drop, the better the outcome. So patient who received apalutamide had higher 90% PSA drop as compared with patient who received enzalutamide. And patient who received apalutamide also had faster PSA drop, 3.5 versus 5.1 as compared with enzalutamide. And all of these trials showed that the lower the PSA, the better the survival outcome. And the faster time to a deeper PSA with apalutamide correlated with long survival outcome. This is another study from the real world data Oasis. This is a retrospective study that evaluated patient who was given different type of androgen pathway inhibitor, apalutamide, abiraterone, and enzalutamide, and the author performed inverse probability of treatment weighting, which is a statistical method. When you have like different sample size of different treatment modality, you have to adjust for these differences, and you have to adjust for the missing data. And it was presented in ASCO GU, and they reported better survival outcome and better risk reduction as compared to other arms. But we have to be cautious while interpreting this data, and we have to interpret it within the limitation of the retrospective study design. So several network meta-analysis, and this is from the European guideline, combination therapy is more efficient than ADT alone, and we agree on this, okay? And none of the doublet combination has been strongly proven to be superior than the other one, because there is no head-to-head comparison. And it seems that all patients with de novo or synchronous metastatic prostate cancer will benefit from the combination therapy ADT from androgen and androgen pathway inhibitor. From the slide that I showed you previously, the landmark trial, أنا لازم أعيد صح هيك؟ الله يخليك يا هلا. And from this landmark trial, 2 trials now remained, which is the PEACE-1 trial and the RCSense trial, and those trials are interesting because unlike other trials, they are multi-arm, and the standard of care was different, which is ADT plus docetaxel in many patients, and the other arm was abiraterone radiotherapy, and the author concluded that abiraterone acetate and as compared to the standard of care, it improved overall survival and radiological free survival. The RCSense also provided the concept of newer androgen receptor pathway inhibitor, which is the darolutamide, and it showed improved outcome in men with metastatic hormone-sensitive prostate cancer. So how about triplet therapy? And I mean, several systematic review and network meta-analysis confirmed that triplet are more efficient than ADT and docetaxel alone. So docetaxel, in addition to the ADT alone, should not be considered as a valid option in case you have available androgen receptor pathway inhibitor, and there is no clear contraindication to give it. So androgen deprivation therapy plus androgen receptor pathway inhibitor, apalutamide, enzalutamide, abiraterone, dolutamide should be considered on all patients, and triplet therapy in addition to docetaxel should be discussed with the patient. Now, is there an added value for docetaxel in addition to the combo, which is ADT and androgen receptor pathway inhibitor? One meta-analysis suggests the benefit of adding docetaxel, and another one showed that the benefit is only in patients with high volume disease. So there's a question, what is the added value? This is remained to be answered. But in the current practice, you have to discuss with the patient that there is no overlap toxicity between these medications, but most toxicity would be driven by administering docetaxel. So you have to discuss those with the patient. This is a suggested slide for how to proceed with or the sequence of medication. I think since there was no strong evidence that one of these is more like superior to the other one, it remains to the physician discretion and a thorough discussion with the patient. But the idea with the Titan trial, with the second progression-free survival, it gives a privilege for this medication to be a starting treatment that would be followed by other androgen receptor pathway inhibitor. And as I promised you, I started with this slide, and I gave a credit to Charles Higgin, who invented, or who the first one to document androgen deprivation therapy. I will finish with this guideline recommendation. It's a benchmark for everybody of us, how to treat and how to deal with patients. Do not offer ADT monotherapy for patients with M1 disease, okay, if there is no clear contraindication and if life expectancy is more than 1 year for other comorbidity. Offer ADT combined with abiraterone acetate plus prednisolone or apalutamide or enzalutamide. Offer docetaxel only in combination with ADT and androgen receptor pathway inhibitor. And regarding the radiotherapy, as most trials show, that it has benefit in patients with low volume disease, 72 gray in 35 fraction. And regarding the role of surgery in patients with hormone-sensitive metastatic prostate cancer, it's still under evaluation in prospective trial. And we should not recommend that treatment for patients unless it's outside the trial. And thank you very much for listening.